Restorative dentistry has experienced an enormous growth in both knowledge and the materials available throughout the past decade. Underlying this has been the success of preventive techniques and a change in the demands of patients who now require even higher quality aesthetic and conservative restorations. The development of adhesive restorative techniques has been at the forefront of these advances, but this has meant that the dentist is now confronted with what is perhaps a difficult choice of effective treatment options. The intention here is to assist in this selection by reviewing the mechanisms of adhesion and the application of these techniques in clinical practice. Adhesion is a general term for surface attachment and covers two mechanisms: mechanical interlocking and true PHYSICO-CHEMICAL adhesion, which produces interfacial bonding through molecular attraction. First, mechanical interlocking. This is the basis of all procedures in which composite resins are bonded to acid-etched enamel. This technique has become standard practice, providing increased retention and decreased micro-leakage. Problems with this technique can often be traced to a lack of moisture control following etching of the enamel, or are due to failure of the restorative material itself. The control of moisture from saliva, gingival fluid and breath is a central feature of adhesive techniques, and a rubber dam should be used where possible. Restorative materials have developed considerably from the unfilled acrylic resins that were available to Michael Buonocore when he first described this technique. Whilst these flowed into the etched enamel surface and remained attached by mechanical interlocking, they were not good restorative materials, for they shrank when they were placed, and during service in the mouth changed colour and wore away. Since then, the development by Bowen of the dimethacrylate resins based on bis-GMA, their use in composite restorative materials, and the introduction of the first command-setting materials have all been major breakthroughs. These have undergone dramatic improvements, so that today we have composites which contain almost as much inert, radiopaque glass filler particles as technology can presently achieve. The resins are much more colour stable than their predecessors, and command setting now uses blue visible light. The polymerization reaction which causes composites to set is triggered by an initiator, but the initiator also requires an activator to be added before it can operate. This process can be achieved by mixing two pastes, one containing the activator and the other containing the initiator, but there are drawbacks with using pastes. The polymerization process started by this thorough mixing can be so rapid that there's a danger that the composite will be too sticky and viscous to adequately form the restoration. This problem can be overcome by the use of light as the activator, because this gives greater control of the setting process. However, the dentist must not linger under strong surgery lighting conditions. Once in position, the composite can be activated by bringing the blue light as close as possible. This technique is not without its problems, though, many of which stem from the activator being an outside source rather than mixed with the initiator, because the setting process starts from nearest the light. As it sets, it shrinks, and it will shrink towards the light source. This can cause problems because, in the case of a filling, this could result in the development of a marginal gap. A second problem can occur if too thick a layer is placed, for not only will the material shrink, but as composite acts as a barrier to the penetration of the light, it may not set much below the surface. This could produce a filling with a soggy bottom. This effect can be further aggravated by the use of heavily pigmented composite and an inefficient light source whose bulb is getting old or whose light guide is contaminated. Thorough curing can be achieved by placing a wedge shape of composite and ideally curing from the bottom using a light transmitting wedge. Further wedge shapes can then be built upon this, curing from the top as usual. Using this method, the composite shrinks in such a way as to minimize the marginal gap. The first composites, which we now describe as conventional, contained irregular ground glass or quartz filler with particles with a mean diameter of 20 microns. These materials were impossible to polish, and their resistance to wear was poor. The microfine composites used colloidal silica with a mean diameter of 0.04 of a micron as a filler. These can be polished to a high luster, but still suffer from wear. The modern hybrid composites use filler particles with a maximum diameter of 5 microns, interspersed with microfillers in carefully selected particle size distributions. This can result in a filler mass of 87%, which makes these the strongest and most wear-resistant of the composites with acceptable aesthetics. Composites can therefore be readily mechanically bonded to acid-etched enamel, but such bonding cannot be achieved to dentine. So physico-chemical bonding is required. One of the earliest lessons learnt in dental school is that such direct bonding is an impossibility. Dentine is a wet, porous, sensitive substrate, whereas composites, as we know them, hate water. All of the dentine bonding agents that are currently on the market contain a primer. The role of this is different in each product. Some wet the smear layer of organic and inorganic material and enable a bond to form. Some contain an acid that chemically modifies the smear layer, and others use an acid to remove it completely. But how effective are these bonding agents? Evidence suggests that the bond strength varies, and that it is usually weaker than a mechanical bond to etched enamel. Equally, these values are to the dead dentine of extracted teeth, and laboratory studies may not truly represent the clinical situation. Whilst these materials are undergoing evolution, only time will tell how effective their long-term retention will be. This is particularly true in the case of a Class 5 restoration in composite, part of which is retained by acid etching of adjacent enamel, and the rest may be held by a dentine bonding agent. In these circumstances, there is evidence to suggest that if the filling is more than 2 millimeters wide, then polymerization shrinkage will be towards the strongest bond. As this will probably be to the acid-etched enamel, the dentine bond is likely to fail, and leakage at the composite dentine interface may follow. A different approach to physico-chemical bonding followed from work in Manchester in the early 60s on water-based polycarboxylate cements, which form when zinc oxide reacts with a solution of polyacrylic acid. These cements form physico-chemical adhesive bonds at the interface with either enamel or dentine. Later, the laboratory of the government chemist in London developed the glass ionomer cements, using an acid-leachable glass derived from the silicate cements and a mixture of polyacrylic and other carboxylic acids. These materials react to produce a cement which forms durable adhesive bonds with both enamel and dentine. When first introduced into the profession, their setting rate, translucency and resistance to dissolution were not satisfactory. However, these properties have all been dramatically improved over the last decade without losing either their adhesive properties or their ability to supply fluoride to the adjacent enamel and dentine. The development of Cermet ionomer cements and light-curing glass ionomers has extended the properties considerably. Advantage can be derived from the combination of metal and glass in a cement. Simple mixtures do not increase the mechanical properties in any way. However, if the metal and glass powders are sintered together at 800 degrees Celsius, the resulting powder produces a cermet. Cements made with these powders are not only adhesive and a source of fluoride, they are also radio-opaque and somewhat more resistant to abrasion than the conventional glass ionomer cements. The light-curing glass ionomer cements use an acid molecule which also possesses a light-curing component. Whilst they chemically bond to both enamel and dentine, their setting reaction can be accelerated by exposure to blue light. So far, these materials are only suitable for cavity linings and bases, but it's early days yet. The use of glass ionomer as a replacement for dentine is a valuable technique. In this procedure, which is particularly suitable for those cavities where only part of them is surrounded by enamel, the ability of the glass ionomer cement to form an adhesive bond to the dentine and to provide a source of fluoride is used. Once set, the enamel only needs to be etched before a layer of unfilled resin is applied over the cement and the enamel. A composite is then used to replace the lost enamel. A mechanical bond is formed between the set rough surface of the glass ionomer and the composite resin. With this abundance of possibilities, let's now consider some clinical problems and demonstrate some of the treatment options available. A common clinical problem is the erosion-abrasion cavity that needs restoration. The treatment options for this are to place a glass ionomer restoration, to restore the bulk of the cavity with a glass ionomer filling material and cover the external surface with a veneer of composite to enhance the wear resistance and aesthetics of the restoration, to use a dentine bonding agent, also etching the available enamel and restoring with composite resin, or to place a glass ionomer lining, etch the enamel and restore with a composite material. In a cavity that is not shallow, a combined glass ionomer lining with composite has much to recommend it. With this technique, the dentine surface is coated with a polyacrylic acid conditioner, having first been cleaned with a slurry of pumice and water. A layer of about 1 millimeter in thickness of glass ionomer lining is now placed, covering all of the exposed dentine. Of course, in a deep cavity, a little calcium hydroxide would be used to protect the pulp. Here, a light-cured glass ionomer material is used. This considerably reduces the time it would take with the conventional lining material. Etching gel is carefully applied to the surrounding enamel margins. There's been much discussion about the desirability of etching the glass ionomer to improve the bond. As this can damage the glass ionomer, it is not recommended and care should be taken only to etch the surrounding enamel. Following washing and drying, a thin air-blown layer of unfilled bonding resin is applied over all of the cavity and cured. The composite restoration is then built up, shaped and cured following conventional techniques. The restoration can now be finished with care taken to remove any marginal excess. Fine-grade diamond burrs or multi-fluted tungsten carbide burrs are initially used with great care. Flexible abrasive discs are then used in order to end with the smoothest possible surface. Diamond impregnated rubber points or a diamond paste can produce a final luster. On this radiograph, one can see a carious lesion just extending into dentine. The patient, though, generally has a low caries rate. Adhesive restorations are able to exploit minimal cavity designs and would be valuable here. An appropriate technique for this case is a tunnel preparation. Under local anesthesia, with a matrix band placed to protect the adjacent tooth, an initial access is made through the enamel from the occlusal surface inside the marginal ridge in the adjacent occlusal pit. Access is made, cutting obliquely towards the carious area. Once the caries is reached, it's removed using a slow-speed rosehead burr, rotating the burr buccolingually around the cavity. Tactile sensations are essential to ensure adequate caries removal. The occlusal access has to be large enough to allow a small excavator or a brio probe to run around the cavity to feel for soft dentine. Vision is difficult here without the use of magnifying loupes. Any weakened proximal enamel around the cavitation can be removed, but the proximal opening is not enlarged more than necessary. If the caries is more extensive than initially expected, a conventional cavity design can be instituted. As we cannot ensure complete caries removal, a radio-opaque glass ionomer, in this case a CERMET, will be used to reduce micro-leakage, provide fluoride ions in the susceptible proximal area, and restore the strength of the tooth. The glass ionomer cermet material is injected into the occlusal opening. To reduce the chance of voids, the material must be freshly mixed and the occlusal opening must be large enough to take the tip of the syringe into it. In this application, the occlusal surface will be protected and the aesthetics improved with a posterior composite restoration. So much for the bond of materials to tooth. We should now consider the bond between differing materials themselves. Take, for example, resins to metals. To obtain mechanical bond, the metal surface can be treated either chemically or electrochemically, as in this SEM, to produce an etched surface similar to etched enamel, as in the Maryland Bridge. Or some other mechanical surface could be produced, such as that created by the crystal bond technique. In these cases, retention is achieved by mechanical interlocking of composite with both surfaces. An alternative method of attaching resin to metal is to use PHYSICO-CHEMICAL bonding. A base metal surface, which has been grit or sand blasted, is essential for this process, and a composite resin containing a bifunctional primer is used. The bifunctional primer links the metal to the resin, which mechanically bonds to etched enamel. Adhesive techniques have been successfully adapted to allow for more conservative bridge work. The various retentive techniques for this have already been discussed.
Well, what we're going to do is to prepare the inner surface of your incisor tooth next to the space so that it's able to receive the bridge that we're going to make for you.
Tooth preparation is designed to give the maximum area for bonding by extending over as much of the tooth as possible. Some form of occlusal seat is also required for the framework. Anteriorly, this may be produced by developing a cingulum notch. On posterior teeth, this takes the form of shallow rests on the marginal ridge areas. An adequate amount of clearance should be provided if necessary. Minimal tooth preparation is used to enhance the enamel bonding. It's carried out without a local anesthetic and must remain only within enamel. Restorations within areas required for bonding do not contraindicate adhesive bridges, but they need to be replaced with glass ionomer or composites to which the bridge may bond. An accurate rubber base impression is used and no temporization is normally required. On the next visit, the framework is first tried in and the fit and aesthetics of the bridge checked. If an etched metal bridge is to be used, it should now be sent to the laboratory for etching. However, in this case, we'll be using a composite resin cement containing a bifunctional primer, and so the fit surface of the bridge has simply been grit blasted. For cementation, strict moisture control is necessary, and when working on the palatal surfaces of teeth, the rubber dam is the best method for ensuring moisture control. The tooth surface is cleaned with a slurry of pumice and water, etched, washed, and dried. The composite resin is applied to the cleaned and dry fit metal surface and the framework firmly seated onto the tooth. Excess material can be wiped away from the margins, but it is essential that the composite lute is not disturbed while setting. As this material is prevented from setting by the presence of oxygen, some isolation medium is applied around the margins. Following complete set of the material, any remaining lute is removed and the margins checked. The rubber dam is removed and the occlusion inspected. If adjustment is required, care should be taken not to heat the metalwork.
There we go. Just take the mirror. Just hold it there.
Veneers of porcelain can also be bonded to enamel via the acid etch route. However, in order to obtain a bond with the porcelain, its fitting surface has to be roughened, either by etching in the laboratory with a hydrofluoric acid derivative or by light sandblasting. To enhance this mechanical bond, the veneer is coated with a layer of a bifunctional primer called a silane. This has the ability of forming a chemical bond to both the porcelain and the composite resin. The veneer is thus bonded by a combination of mechanical and physico-chemical adhesion. Take, for example, this case of a patient requiring veneers because of unsightly mottled and pitted enamel. A minimal preparation technique is used to reduce the labial surface by 0.5 millimeters, great care being taken to keep the preparation within enamel. A series of depth orientation markers are initially cut, and then the labial enamel is reduced, finishing with a chamfered margin extending just short of the gingival margin and the contact area proximally. If the enamel is perforated gingivally, this will decrease bonding, and one would have to rely upon dentine bonding agents for a marginal seal. If the incisal tip area is not intact, or it is desired that the length of the tooth should be increased, the veneer can be extended over the tip and a suitable surface needs to be produced. In this case, the veneer will be extended just to the tip, forming a butt joint. Accurate elastomeric impressions are now taken. A temporary restoration is not normally required. On the subsequent visit, the veneers are tried in to check the fit and colour match. As the veneers are fairly translucent, the composite resins are coloured to allow for minor changes to be made at this stage. For this patient, it was considered to be an advantage to use a rubber dam for the cementation. If this is not possible, strict moisture control must be maintained. Conventional etching, washing and drying are carried out. The veneer surface is cleaned and the silane coupling agent is applied. The tooth surface is then isolated with interproximal strips. Luting resin is applied to the veneer, which is then gently seated incisally first onto the tooth. Light-cured resins are used, and a short 10-second burst will tack the veneer to the tooth. Using a brush dipped in bonding resin, the gross excess lute is wiped away from the margins, and then complete curing can be carried out. Finishing of the margins may be achieved with diamond points, rubber cups, and fine polishing paste. This technique can be used to repair fractured tips, to close spacing, or to mask the appearance of rotated or non-vital teeth, etc. But important points in case selection include good oral hygiene, a low and stable caries rate, and favourable occlusal loads. Clinical trials results are favourable, but it is early days for the technique, and care must be taken to ensure that every stage is followed. These students are facing exciting new developments in the future, particularly in the area of adhesive filling techniques. Take, for example, posterior composite materials. There are still many problems with these, in particular the amount of polymerization shrinkage leading to lack of marginal integrity, the sensitivity of the technique, and the unresolved problems of wear and stability of the material. Techniques are now available to construct laboratory-made composite or porcelain inlays which can be cemented in with composite luting resins. These techniques overcome many of the objections levelled at directly built-up posterior composite restorations. Cavities are prepared to receive an inlay, and provided that an adequate bulk of material is used, a composite inlay or onlay can be formed on a stone die made from a suitable impression. This can be adapted so as to produce adequate contact points and then thoroughly cured outside the mouth. Various combinations of heat, light and steam pressure are used by the systems currently available. After polishing and trimming, the fit surface is sandblasted. The inlay requires coating with unfilled resin before it's luted into place with a composite cement. An interesting development is the machining of an inlay from a solid block of pre-fired porcelain using a computer-controlled milling machine. This works to a design based on an image produced by a small intraoral television camera connected to the computer. Other methods are available for the construction of porcelain inlays, including conventional techniques and the casting of glass ceramic materials. A porcelain inlay can provide even greater resistance to wear, although care is needed to prevent too much wear of opposing teeth. So this video has shown a range of treatments using either mechanical interlocking or true physico-chemical adhesion. Whichever is selected, the important features are strict isolation must be maintained throughout all bonding procedures because of the problems of moisture contamination. Bonding to dentine is not as reliable as that to enamel, and so enamel margins must be retained where possible. As most of the techniques rely on the placement of layers of material upon each other, care must be taken to follow all stages and manufacturers' recommendations when using new materials. Many of the techniques are under-researched, and the operator is essentially running his own clinical trials. As technology is moving quickly, awareness of new developments is vital. Adhesive dentistry is an exciting, changing field, and the practitioner can look forward, albeit cautiously, to placing highly aesthetic, conservative and retentive restorations for their patients in the future.
Excellent. Thank you.
Good.